Hey, Michelle. So good to see you. Glad we're doing another remote recording episode.
We are. Hold in there for just some of the technical glitches. We were just talking about another episode that we had where we put some outtakes in there without actually calling them outtakes, and that was pretty good.
Yeah, absolutely.
So today we're just going to get into it and talk a little bit about narcolepsy. So for decades, if you were diagnosed with narcolepsy, the whole idea is it's medical, it's the same. We have, one, two, or three different type of things. So it's really heavy on the stimulants to keep you awake. And then we do this other thing where we put people's brains to sleep. We tell you, I'm sorry, you're always going to be tired. We're treating you for the symptoms, but we're not actually fixing the problem.
But what if you could just replace the exact brain chemical that narcolepsy takes away? No more band-aids, just targeting the disease right at its root.
And that's what's happening with the new generation of medications. They are nearing completion of FDA approval. There's going to be 1, 2, 3, 4 of them coming out. And they don't just wake you up, they actually address the biologic problem that's happening with the wakefulness system. And it's probably the biggest medical breakthrough that we've had in the sleep world for quite some time.
Wow, I'm excited. Well, I'm Dan.
And I'm Michelle. I didn't quite know where we were going, but today we're going to break down the new roadmap for treating narcolepsy.
Good thing we can edit out these comments in the script. So we'll just have to proof this before we click produce. All right, so we are going to show you exactly how these revolutionary new orexin-targeted drugs from Takeda work, why these are kind of a massive upgrade over traditional stimulants, and we're also going to talk about the science-backed behavioral therapies that you can start today to take care of your sleep when narcolepsy is a big piece of this.
We're going to get into it, but we talk a lot today about on the podcast what we can do to treat medicine better, to treat sleep better without medicine. And narcolepsy is one of those things that we've needed to use medication to actually give things back. So if you're not really quite sure about narcolepsy is a little bit like the type 1 diabetes, where an organ does not make the insulin in diabetes. And in narcolepsy, your body doesn't make enough of this hypocretin or orexin. Because the molecule hypocretin and orexin was discovered around the same time, they use them interchangeably. They're the same thing. And they're really trying to get away from the hypocretin because it's a weird word from the Latin. And they're trying to talk a little bit more about orexin. But if you ever see anything about them, they're really the same thing. So narcolepsy is a neurologic sleep-wake disorder where someone doesn't have enough orexin in their brain. Orexin's in other places, but it's really localized in parts of our brain that are the sleep-wake centers. So not only do you have trouble staying awake during the day, but you actually have a lot of trouble sleeping solidly at night. And so we end up having this system where if you want to live like everybody else, we have to keep you awake with a bunch of stimulants or antidepressants that make people awake, and we use those in the day. And then if you have trouble sleeping at night or the vivid nightmares and hallucinations, which is one, as you're falling asleep or staying asleep, those are called hypnagogic or hypnopompic hallucinations, depending on if it's as you're falling asleep or waking up from sleep. The other really scary part of narcolepsy that happens during sleep is people get sleep paralysis. And that is where you actually wake up from the stage of sleep where your body's paralyzed, but your brain's awake. And so you can't move, talk, sometimes see, because your body is taking a little longer to wake up where you can move. And it's frightening because you think you can't breathe, you can't move. And if you have these nightmares or vivid dreams or hallucinations on top of it, you may think there's something in your room and you can't get away. And vivid dreaming is that other thing that happens. Now, you may have heard there's different types of narcolepsy, but narcolepsy type 1 is the one where in the day you can have cataplexy, and that's loss of muscle tone from the spinal cord, and it happens out of the blue while you're awake. Again, if it happened while you're sleeping, that's what we normally have during our REM cycles, but this is happening during the daytime. So we use different types of medicines that are more preventing the cataplexy. So sometimes these people are going to be on 3 or 4 different medicines multiple times a day to treat one condition, independent of some of their other medical problems. And that's provided some of the limitation is we're putting generally young and healthy people on a lot of medicines and creating this side effects. So the shift is going to be targeting the disease with the molecule itself. And this has been tried for a long time, but now we finally have what looks like some safe drugs that are trying to keep the brain awake using orexin and basically binding those receptors. So we're giving the body the substrate to bind the receptors to act like orexin in the body. So the newest one that seems to be coming down the pipeline, and I'm not going to use the regular names, but they're all TAK, so TAK. So the next one is TAK 861. And Oveporexton is a highly potent molecule. It's readily available for the orexin 2 molecule, and it's going to be produced by Takeda if it comes to this country. It is being produced by Takeda in other countries right now, and it looks pretty good. So it is a milestone from the FDA that they are looking to produce this drug. In the phase 2 and phase 3 trials, it demonstrated that it significantly increased the time it took for people to fall asleep during the day when they were sleepy, and it decreases the amount of wake ups at night and if somebody has cataplexy attacks. So the limitation is going to be it's only being approved for people that also have cataplexy. Okay. There's another molecule, again, not out yet, the TAK 925, and it has also been shown to reduce daytime sleepiness, but it's going for both the cataplexy diagnosis, narcolepsy, and the non-cataplexy. And that will be really helpful because it's going to get a number of people that won't have the ability to get the regular medicine. So those are the 2 new ones that are from Takeda. And there's a couple other ones, but again, I think it's still a little early since they're not readily available, but just know that's the medicine side. On the behavioral side, Dan, I want you to kind of go over what we were talking about before is the non-medication ways that we really want to encourage people to identify so they have more control of their disease.
Right. Well, and I think too, Michelle, thank you so much for going over the kind of the molecule kind of perspective of these things, because I think it's really relevant to kind of look at the specific kind of targeted piece, and then acknowledge too that what we're about to talk about from a behavioral perspective, these aren't magical changes, but what they are doing is you're trying to reduce the overall additive stress of multiple kind of pieces on this. And the first one here for a lot of our kind of listeners that might be kind of living with narcolepsy is to schedule your daytime napping. And this really kind of comes from the idea that strategic naps are often a really effective kind of non-pharmacological method to kind of manage that sleepiness. And what's really kind of interesting about that is, it's really focusing on, instead of it just being kind of a long afternoon nap, you're really just kind of taking some of these briefer kind of naps, maybe like a 15-minute kind of scheduled nap throughout the day. And then that kind of leads a little bit like of that recovery, like recuperative benefit. And it also improves your reaction time with minimal sleep inertia kind of impact on that. So that's really kind of one strategy that you can kind of take. Michelle, what are your thoughts on that of like scheduling like the 15-minute nap for our people, our listeners living with narcolepsy?
Yeah, I mean, that may be even a little bit long for a nap in a narcoleptic person who could go into REM sleep in under a few minutes. So keep the naps as short as possible. I think 15 minutes would be a good starting point. But if you're not waking up rested and restored from that 15-minute nap, cut it in half. And when you shorten those naps, that decreases the disability and the interruption of your day. I call them nap breaks, smoke breaks to people because, other people are going to go to the bathroom because they're drinking a lot of coffee or they're going to be going outside to go have a smoke break or have some snack. If you can shorten your nap period, you can make it less likely to cause interruption where you may be self-conscious about taking yourself out of your workforce.
Yeah. I think the next kind of tip is really kind of consistent with all of our other listeners, living with insomnia, but really for those living with narcolepsy, it's about having structured sleep schedules, and really this is about enforcing a predictable routine of consistent sleep onset and wake times every day. And really the goal with this is just to kind of reinforce your body's natural circadian rhythm, so making sure that that predictable sleep pressure aligns with those circadian kind of rhythms. And another kind of key thing, which I think is relevant for all of us, is really avoiding intense kind of stimulation just prior to our scheduled bedtime. So again, thinking about that those buffer zone activities you can do before, entering into rest. Utilizing some relaxation techniques, of which we've done several on the podcast here, can assist you in kind of extending and improving your overall quality of kind of that nighttime sleep period. But essentially, just making sure that you have that predictable routine and that you're not doing things that, alert your brain right before you go to sleep. The next part here is a specific intervention. It's called cognitive behavioral therapy for narcolepsy. And this one really kind of focuses on sleep satiation, some sleep hygiene recommendations that are specific to narcolepsy, and then really focusing on structuring your naps to effectively navigate what the narcolepsy experience is. The other part that those were all the behavior parts of that CBT for narcolepsy. The cognitive part is really focusing on those negative beliefs and those emotions around the disease, around what you're able to do with your life, a lot around some of those self-limiting beliefs, because really the goal is to kind of minimize some of that high emotional arousal that can really act as a trigger for narcolepsy. So especially connect for a trigger for like that cataplexy if you get really activated, really frustrated from that perspective.
Yeah, I
And then
mean, sometimes you're talking to, whole families, Dan. I'm sure that if you're talking to a teenager or a younger person or older person, the other family members look at them like, well, how do I navigate this between the medications and the behavior? So this is a really positive behavior and restructuring part of, hey, I'm taking medicines so that I can live my best life. Hey, I'm doing these behaviors with the napping so I can live my best life.
absolutely. And this is really where again like a dietary kind of piece is relevant too. It's not that diet cures this stuff. It doesn't. But we do know that certain foods and eating certain foods do play a role in this. And that's really like avoiding heavy meals, kind of minimizing simple sugar kind of intake. And really the goal with that is you're trying to prevent the steep drop in kind of your daytime alertness that typically follows, when you eat carbohydrate heavy kind of meals. So again, it's not that this is curative per se, but it is about managing it. And really, all of us can kind of benefit from that perspective. So,
Yeah.
yeah,
So, I mean, the to sum it all up, really, the future is looking brighter in terms of the medicine. So we can directly work with the orexin molecule that's the deficient part in this disease so that we're not throwing multiple medicines that are causing a lot of other side effects, and that we're working with cognitive restructuring and behavioral management so that the person and their families have much more, I guess, control over what we're doing.
yeah, absolutely. Well, all right. Well, thank you to our Sleep Nation kind of listeners, watchers, viewers, and we're looking forward to next time.